Okay, so we're not having a breakout. Okay, so I am to a certain extent a bit of a change in pace because my research, I am not a clinical educator, and I really admire anyone who is a clinical educator because I always think that I struggle with many of the skills required to be a good clinical educator. I guess I would describe myself as a clinical researcher, a clinical scientist. I have about 85% salary coverage right now from the NIH for working on two different studies related to issues of child maltreatment. And I think I'm pretty fortunate to have gotten that. I've had a really supportive university and division and department. But I think in listening to some of the people who've talked to me talked prior to me, I wanted to just, maybe because I have the benefit of being towards the end here, reflect on a few things which I think have sort of themes that come up in my mind. I grew up in a house with a father who was in the public health service. He did a lot of research all over the world. He still does this. And I have at so many points during my career called him up. I said, Dad, I don't like academic research because everyone's always fighting and and I don't really think they want to fix anything. They just want to publish something. And I don't understand the difference, I'm sorry, David, between quality improvement and research. And I don't understand the difference between qualitative research and quantitative research if the goal is actually just to improve what we're doing for our patients, for our students, and for all of those people. And so I think there are a variety of battles that occur within academic medicine and probably academic social work and all of our other professions that I hear, and I think we become, as people involved in violence research, a little defensive about because we're sort of we're like the new folks on the block, or we somehow are viewed as less rigorous or something like that. And I would encourage all of us as we go forward to try not to be overly defensive or apologetic, to sort of say, like, you know what, the difference between clinical research and educational research doesn't exist. They both have to be good. Okay, and they both have to have results. They both have to be good. There's similarly qualitative research and quantitative research. I would argue that people who stand up in front of a poster about the epidemiology of violence and tell you that you can't have that, that's not good research because it's not a randomized controlled trial should be referred back to the JAMA studies, how to do research studies, because that's not the user's guides would not suggest that. For those of you who don't know, the user's guides in JAMA are very handy for that type of thing. For research on harms, which is what violence is, they'd say, very straightforward, you don't do randomized control in this. If you did, it was a mistake because you found out your drug didn't work and it caused everyone to have a heart attack. So you don't go out and do it on purpose. It's not a randomized controlled trial. And referring people back to that without being overly defensive or rude, but say, actually, the kind of research I do isn't amenable to that. I think it's a really important thing. Similarly, I don't see it in this group, but I've worked in groups where there's a huge division between people who do child abuse and intimate partner violence research. And obviously, this group doesn't feel that way. But
Come to a board meeting.
Okay, no, I've heard about them, and they're long. Anyway, I have a very short attention span. Anyway, so thank you for letting me wax on. Anyway, but I think what I was supposed to do is to talk about my experiences as a junior clinical researcher in an academic institution doing research specifically in child abuse. We're going to call it family violence, but my examples will be in child abuse, and I'm not going to apologize for that, but that's what I know. And so I think there are huge opportunities in this area. For all my frustration with academic medicine, I do feel like I've entered an area that's just ripe for research. I think Candace referred to the idea that there's just so much being done without evidence, and it would be so nice to have some. And it spans the entire spectrum of what we look at both clinically and in research: prevention, identification of abuse and maltreatment, and then going on to interventions. And of course, these are all very multidisciplinary areas. I tell my mentors I have ADHD when it comes to research, so all of these are things that I've either got something going on or have written a little proposal for. I'm not doing them all. But you can find things, in the social field that are involved with prevention, with identification. Should we be mandated reporters? I know we're not doing a randomized control on that, but it's an interesting question. Where should we be placing children as intervention? What kind of community resources work? Through health, which many of us know about. I haven't even gone into biological aspects because that requires someone who knows how to run a lab. And into law, how do we provide expert testimony? How do we do forensic interviews? All of these are interesting and fascinating questions which have less than adequate evidence, at least I think. I may be wrong, but that's from what I understand. These also, so the last I say, it was subtle. Opportunities, these also present challenges, and each one of these areas has a challenge associated with it for many reasons, and I'm going to run through some of them. So both an opportunity and a challenge is that this is so multidisciplinary. I think one of the things, actually we were in the small group discussing this, is that so someone decides they want to do some research in the biologic basis of the mental health after effects of, I'm sorry, Brooks, of child abuse, and finds that the pediatricians in the group just aren't interested. And so you suddenly are outside of your sphere of comfort, perhaps. Similarly, if social work is interested in health consequences, they may have to go elsewhere to find someone interested who can help collaborate with them. And so we all have to travel outside our sphere of comfort. And that's both interesting and sometimes a little frustrating and time-consuming. We also don't speak same languages and things like that. But each of our disciplines may define the problem differently. Some people are worried about the acute safety of a child. Like, is the child who's coming into my office going home to a safe environment? Is the child who CPS is seeing in the office or in their home right there, are they safe at that time? What is the disposition of the child? What is the safety plan for this child? Those are the important things. For many of us in mental health and in pediatrics and in general medicine, internal medicine, maybe what we're seeing are the after effects, the things that happen 5, 10 years later. And that's not only a different question, it's a different research area. You can't do the same research on that. And for people involved in law, the question of what creates a civil society, how do we punish people, how do we find justice for children who've been abused, which is something that I in some ways I don't even like thinking about sometimes. But that's a really important question because all of these things are working together in like one big moving machine. And if we ignore each other, it doesn't get we don't move the field forward. We also similarly have different definitions of success. I know people that I work with who are sort of offended by the whole concept of family violence, and all they care about is primary prevention. And if you can't accomplish that, basically it's a failure. And they have a really hard time talking with me, and it's really, I'm like, you know what, if someone gets the flu, we don't think like, okay, well, what are we going to do now? We put them in the hospital, we treat them, I mean, we have other steps. But there's some people who really have a hard time with this in our field, which I find interesting. For CPS and for some other groups, it's case resolution, which, where did the child end up? Was there a permanency plan established? What happened to resolve sort of that legal investigative piece? For me, again, not where I am interested in. I want to know what happened after that. Legal outcomes I think are just starting to be investigated from a research perspective, but are fascinating. And I think we can really work with some of our legal colleagues, although I'm not sure how many people do. I don't know does social work correspond with them a lot more? I mean, I know that you're an outlier here, but with your JD and all. But they are starting, at least for child abuse pediatrics, we are starting to hear more from lawyers. They are publishing more, and it's starting to become an interesting dialogue, which we may want to be more proactive in talking with people about. And then actually an area I'm interested in is this issue of secondary prevention. What do you do after abuse has happened? And how do we keep it from either happening again or causing more problems downstream. And yet I'm not a mental health, I have no training in mental health, and I may have no mental health. And, but I find people to collaborate with, and I work on it. I think sometimes though, especially I would argue in academics, we sometimes are like, no, this is my project. And that sort of collaborating with someone across a college line or a department line may be a little difficult, and we need to work on that. I put a lot of words on the slides, but anyway, defining the problem. So the other problem is, how do you come up with these research issues? It's not, I mean, I always think infectious disease is so easy because like they have these tests and they can decide whether or not someone has flu. And yes, I understand sometimes they have to go by the billing sheet and whether it's like a clinical flu syndrome or not, but really that's got nothing on the problem we have. So defining abuse is a problem. Do you say it's self-definition or a legal definition? Did all of the subjects in the ACE study, they reflected that they might have had these adverse child experiences, but did they really? And so then we have the long scan, the longitudinal studies of child abuse and neglect that followed children prospectively and reviewed their CPS records every 2 years by hand. You know, so that's a legal definition, but to be honest, they had controls that were, I mean, they were the same, really, because they were, you know, I mean, they looked the same in many of the outcome studies associated with that. And so, you know, but trying to understand exactly how you are going to define and just be able, you know, again, without being apologetic, recognizing there are limitations to any research involving this. How are you going to define abuse, maltreatment? And I think it's probably even harder in intimate partner violence since we don't have that, you know, you don't have the CPS records to review by hand every 2 years. So understanding what you're really interested in, how that affects your question and how that affects your methods for research. I think another issue is that we sometimes have put together, again, I'll go back to the infectious disease model. We would never group together all the different kinds of infectious diseases because we know that there are viruses, in which case your doctor says you just have a virus. Or there are bacteria, in which case we give you antibiotics. Or we have no idea what that is, and then we just send you home. But we would never really think about comparing all of those as if they were like the same. And yet we do this pretty frequently with maltreatment issues. I think also in IPV, sort of, you know, emotional abuse versus physical abuse versus sexual abuse. I think these things are often lumped. And I think we need to be cautious about that. We also may not be taking into account always the issues of chronicity or timing or what the interactions between multiple forms of abuse occurring simultaneously are. And so those things need to be pieced out. And that creates a lot of difficulty because sometimes the records just aren't there, or they only like to tell you what the prime, you know, the first most worst thing was, which may not actually have been the worst thing. It was just the safety issue at the time. So, and I'm sure that's true actually in intimate partner violence because it's what brought the police to the door. And you may not ever know that she was also raped last week or something like that unless you interview her. So I think that's a big issue. And then the other issue, which was touched on previously, is who are your comparison groups? Because I don't think that randomized controlled trials are correct in this sample. I joke about it, but I think that both from a research perspective and from an ethics perspective, there's problems with that. But you do need to be able to justify your comparison. You may not be able to compare maltreated subjects with just anyone else who shows up on an administrative database. I know that some of the foster care studies that involved Medicaid data compared those kids to the kids who received SSI as if they were kids with disabilities, which I sort of wonder about the logic of that, but that was the decision they made because they said we can't just compare them to everyone because that's not fair. Similarly, can we compare the children who come into a hospital with abuse-related injuries to, and I think it's an important one. The other challenge that research in family violence faces, which I don't think I can. Well, I can equate to infectious disease if we go back to when AIDS and HIV were coming out. It's an emotional topic. People had very strong gut responses. And a lot of times policy is going to precede any wisdom that we get through research, which makes it actually almost impossible to research. Almost. Sometimes we can still figure out a way to do it. But it's not to say that's bad. And I think another battle that gets fought is advocacy versus research. And I'm not sure that that's an appropriate battle, although I have expressed frustration at times. But you would like to argue for evidence-based interventions. But sometimes in the absence of evidence, you might just have to do something. You might just have to give it your best shot. What's best is if we know people who are working in policy and in advocacy and in the legislation, and I know this group does that, is to make sure that as things change, as CPS decides, in our state, maybe to change how we're going to respond to domestic violence reports, because we do have a mandated domestic violence reporting CPS mandate. I said that really well. I think, making sure that we, at the moment when they're talking about making those changes, say, is there any way we could come in and as that's happening, look at this as a natural experiment? Could we come in and right now, because we've just happened upon this, could we follow this from a research perspective? Could we go ahead and right now, really quick, write up a little idea? Probably not going to require too much funding since you guys have already decided to do it. Just see if you can piggyback onto a natural experiment that's occurring. Advocates for children's rights are strong. Advocates for parents' rights are strong, and it is really hard to argue with those. I mean, I published something in Archives of Pediatrics a couple months ago, and I got grandmothers calling me. It was really very interesting. I was like, I'm really sorry. How'd you get my phone number? Anyway. And I was like, I think you only read the editorial that went with it. So it's, research in this area is emotional, and experiences, everyone has very singular experiences. Anecdotal experiences mean everything. And the other thing I've learned, because one of my mentors is a PICU physician, an intensive care physician for pediatrics, and so she sees trauma. I mean, she's done a lot of trauma work. She's doing something right now where she has to read child abuse pediatricians' consultations, their clinical consultations. She called me one week and she's like, God, this is so depressing. I was like, really? I mean, because I was reading them too, and I thought it was sort of normal because I'm strange. But she was really, I don't know, she thought that was pretty tough. So I think we do need to pay attention to, as we're doing this work, is it having a negative impact on our own emotional life? And finally, the other obvious research quandary or challenge in our area is the IRB, the ethics, the just plain old logistics to getting some of this work done. And again, one thing I'm going to argue is that these are not unique to our field, okay? I can't tell you how irritating it is to me that if I'm doing research on children who have had skeletal fractures and we want to look at their x-rays, the IRB gets upset because they say, well, what if you find more fractures and so that child might have been more abused? I say, we already know they were abused. It doesn't matter. Why don't you ask the ED when they do the pneumonia studies what they're going to do when they find a rib fracture? Because it wasn't found before. That's actually the bigger problem. But because you've got child abuse in your title, you've always got to think about that. But again, if we frame this as, we are not unique, we're doing research, we're trying to improve lives of people, you need to think about how you will respond to that. We do obviously have true ethical quandaries. We work with vulnerable populations, we work with children, we may work with children in custody, we may work with parents who become prisoners, okay? We have secondary subjects, especially in pediatrics, which need to be considered, although in intimate partner violence, similarly. If you're asking moms or you're asking women about something about their children, or you're asking them something about what their husbands did, you have to at least consider in your mind that you have a secondary subject and you may need to address that in the IRB. And it's sometimes nice to just skim over it and hope that the IRB doesn't catch it, but I'm not sure that's totally. Well, it's funny, not all of them will. I feel like I have a fairly liberal IRB, and sometimes I'm like, you guys missed something, okay? Or I'm told I've overthought something. But it is, you definitely need to consider whether that is important in your research. And your response, though, is funny. I think this is one reason why we decided not to do a very large presentation on IRBs, because they are so unique to different institutions. You have to consider legal risks. Is there mandated reporting that's going to come up as part of your study? Do you want to work around that by getting, going to the NIH and getting a, I'm blanking on the name. Thank you, certificate of confidentiality. Or do you want to simply, in the process of informed consent, tell someone, if you reveal something, I will have to go forward and do that? And there are both practical and ethical reasons why you would choose one or the other. I'm doing qualitative interviews right now, and I haven't had anyone even balk at that. But for the most part, these are women who've already been reported, and they feel like they feel like they got out of whatever situation they were in. So it hadn't fazed anyone. The question of violence risk, will participation in a study increase risk for violence, is a huge issue in intimate partner violence. It actually frightens me a little bit. I don't know how real that is, but it worries me. But I certainly have seen case reports where that kind of thing has been described, and it worries me. There's a social stigma, like I had to get a waiver of, an alteration of informed consent because I didn't want to put the title of my study on the top of my informed consent. It seemed really silly. I was like, really? Just because I don't want to put the whole title that says child abuse in it? Like, you really are going to make me do a whole extra piece of work. But trying to think of the risk-benefit ratio is also important. Is important in all research. It gets overlooked all the time. But is the risk and the burden that we're placing on the subjects we're asking to come into, our work worth the benefit? Probably not to them. I mean, most research doesn't directly benefit them, but is it going to provide a benefit to some grander picture? And then, that obviously also creates recruiting challenges. It's harder to hang up signs and say, hey, you've been reported to CPS, call me up. You get a little bias sample.
Well,
yes, go for it.
Comment on that as well, because I had some major recruiting challenges.
Yeah, me
with
too.
My work. Getting the language right. Making sure that we're using words that the people we want to have in our studies understand.
But that the IRB...
words than the IRB would like us to use, or that we would use when we would talk about our research. I say dating violence. Nobody really knows what that is. The
Right.
IRB called it that, and they understood what I meant. But the people I actually wanted to talk to were like, dating? Who does that?
Not the people sitting on the IRB, apparently, anyway. But we know. Anyway, no, and I think that's actually a really, I didn't have to do any informed consents until I reached faculty. I didn't do any enrollment research in my fellowship. And it's been fascinating because I sat through all these talks about how the IRB wants you to use 5th grade language and how they want you to use language that's as if you were talking to the people. And then you go to their form, and there is no way to make that thing less than 7 pages, as far as I can tell. And it's got all these sections that make no sense in the context of my study, and yet you still have to put something in them because I tried to cut them. It didn't work. But so I think the whole consent process, I don't know that I can even begin to explain, nor do I have enough experience to be an expert on it, but it is fascinating. I do think that it is worth, and it sounds like exactly what you did, sort of getting to know the IRB and doing as much as you can with them one-on-one, like figure out the phone number of the person who's helpful in the IRB to say, like, look, this is all I'm doing. I'm just trying to figure this out. Is there any way this is going to go through? And if it's not, can you get back to me and we can sort it out? Sometimes even I've done this twice now, going and sitting on the IRB review while they're reviewing your study, or sitting outside that room for the period of time so that if they have a question, they can call you in. And once I went in and I had a very interesting experience. The other time, they knew I was sitting out there and they were like, no, it's okay, we're fine with it. I was like, okay, great. And so I think those are worthwhile. If you're worried about how the IRB is going to and that was in 2 different institutions. They seem to be pretty receptive to that. So, I mean, they don't wait for you or anything. So I think what I would say is that there are challenges to the research, but there's a lot of opportunity. And so trying to sort of move forward in that way and be creative in what we're thinking. This is from only my perspective, okay? And there are so many people in this room who have such better perspective than I do on these things. So if you are someone who has done this already and who is now in the position of mentoring people, this is sort of where I am and what I've learned. If you're someone who is still trying to move into a faculty position, is considering research, whether it be educational or clinical, these are just the things that I've learned so far. And some of these come from, actually bluntly, I did a fellowship program where I got a master's of science, but almost everyone else in my fellowship was getting a master's in education. So I sat through a lot of medical education classes, and I learned a lot from that. But they were very focused on some key points, many of which translated perfectly well for me. I think one thing is define your career objective. What are you interested in? And we already sat down, we had a breakout session of that, but at least for the next 5 years, because you can change, but do you want to be doing primarily research? I mean, do you want to get grants? Do you want to write for those things? Do you want to deal with having to submit, rewrite, and go back and forth and all of that? You know, the grant that got funded is the last one you submitted, right? Because like you just keep submitting until something happens. But that, you know, that will protect your time. It has some benefits. But if you don't like research, it sort of stinks. Like it's very clear my husband would not like doing this. He's made that more than clear. Research and clinical practice, I don't know. I mean, folks who are more senior than I find that to be an increasingly difficult balance because the whole 50-50 thing, at least within our system, there's never enough time for either clinical work or research. I know people who do this, but I think it's hard because if you still are having to find funding for that research part. People aren't just like handing out that money anymore. I think they used to. My father-in-law keeps talking about the triple threat, and he keeps saying, like, when I was in medical school, they're really good because he thinks this is what I should do. They were really good at teaching and clinical and research, and they were awesome. And I'm like, did they have a life? Like, what did they do? I don't know how I would do that. So I mean, there are clearly more talented people than I, but it seems really challenging. And then people who are interested in primarily clinical practice, but also in still contributing to research, whether it be through educational research or clinical research, there are many opportunities for that. And you may not have to get your own funding. You may be able to do stuff that doesn't require funding, or you may be able to hitch on to someone else's funding. And that can really, I think that is a really great option for people who are doing clinical practice in an academic setting and still want to be doing a lot of, sort of keeping their mind stimulated and doing things like that. It also probably is good for RPT processes. You do need to know your institutional requirements, like, we all get the RPT letters and things like that, and you just need to know what they're expecting from you so that you're not surprised at your 3-year or your 6-year review. You're like, oh, wait, I was supposed to have how many papers? And know your contractual agreements. This was something I just went through my 3rd-year review, and they were like, go back and look at your contract. And thankfully, thank you, David, mine was right. I was doing what I said I was going to do in my contract, but I've sat through reviews of people who actually had contracts that looked nothing like what they were doing and nothing like what they were planning to do. And that was a problem. So you should be real clear on that and renegotiate, before you get too far down the line if your contract isn't living up to what you wanted to do. Again, getting back to if you're going to be doing research, if you want to move past being an advocate in the community and really doing more of a research base, seems strange. I'm not sure unless you've had some sort of conversion experience, but I think it's important to be able to identify it. And some people are really good at being able to say it like 2 sentences. I know people who practice that, like so that if you meet someone, you can tell them what you do. Exactly. See? This is not something I was trained in. You should be able to say your overarching career goal, which for me is what I call my 60-year research plan, although apparently I'll be 100. I just did math, and that was a little worrisome. One of my mentors calls it the overreaching career goal, which I'm fine with as well. And then within that, be able to pull out the specific research questions that you're working on, for the moment. Because you cannot make a career out of your overreaching career goal. It just doesn't work. Like you just keep saying it, and it's like clicking your heels. It doesn't work. You need to have specific research questions. And in that field, underneath that, you want to become the expert. You want to read everything you can get your hands on. And that means going outside of your usual data field. For me, it means I don't just search PubMed. I'll go to PsycInfo or some of the other databases. Google, Especially for people coming into an institution, one thing someone told me in fellowship, which I've always thought about, is it is really much easier to set up like totally like cold call meetings your first year. Because once you've been there already, then you're sort of in this like, I know we should have met, but maybe we didn't meet, or maybe I saw you, but now I don't remember your name. And so, I mean, it's not to say you can't do it. I still am meeting people new in my institution, but it's really much easier when you're new because it's a total excuse. Plus, to be honest, you don't already have like all this stuff on your calendar, at least if you wrote your contract right. And so go ahead and set up those meetings and just go in. And you may never speak to that person again except like passing them in a meeting. And it doesn't mean you didn't like them. It just, well, you know, you're not going to have a research project with them or you're not going to do something with them. That's okay. You know who's in your, you might be able to refer like someone that you're mentoring to them. I mean, I think it's completely reasonable. And make sure you're going outside the field, sort of getting back to that multidisciplinary issue. And so then what you over time do, and it's sort of this continual reshaping, is you're refining what you're really passionate about on the basis of the expertise that you've gained. And mentorship is obviously really important. I think it's important. I know that for me, this became sort of a catchphrase or a catchword when I got into sort of a clinical research program and we were all sort of being trained to write for NIH grants, and so you have to have a mentor there. But I realized once it was a little overwhelming to me because I hadn't heard that term used so spontaneously on a regular basis during most of my training. And what I realized is I had mentors a long time ago. I had mentors in my residency. I still called them when I was in clinical work on the Navajo reservation, during my fellowship when I was not back at my residency institution, and now still call them sometimes. You know, so we all have mentors somewhere, or I hope we do. You know, honestly, my parents are also still my mentors. I still call them sometimes, and my dad professionally as well. So, you know, I mean, we all have people we rely on. In this setting where you're doing clinical research or educational research, you may need to be a little bit more proactive in identifying people who can serve as mentors. You may be, I don't know whether it would be fortunate, you may be in a situation where you find that one person, okay, sort of a monogamy of mentors, who is the person for you, okay, who can coach you in everything from research skills to, you know, clinical skills to, you know, how to maintain your life at the same time that you're doing your academic research. You may find that. You probably won't. I don't know. I mean, it seems to me that would be unusual. You probably need to look across disciplines, across institutions. You may have someone who's in another city that you call all the time. You're going to have people with different personalities. You know, you'll have one person you go to when you have the research question. You go to the other person like when you're having a nervous breakdown. And that's okay. You know, there's some mentors you can cry in front of them, some you can't. It's okay. Probably not too many. But and then if you are seeking funding, you do just need to be aware that you're going to have an appropriately credentialed mentor. And my appropriately credentialed mentor is a fantastic guy. He's not on any of my papers, intriguingly. He won't be because I meet with him every month. He's mentoring who I view my real mentor. He's mentoring her. They're both on my NIH grant. It's pretty clear. I mean, it was one of the comments I got back when I had to resubmit. They were like, are we sure that Dr. Keenan has enough experience? And we wrote back, well, Dr. Dean is her official mentor and Dr. Keenan is her co-mentor, which is true. And I'll tell you what happens, which is Heather, Dr. Keenan, goes to Dr. Dean when I ask a question of Heather that she's not sure. Or if she's worried that I'm not making the right decision in terms of like an RPT thing or something like that, she'll go ask Mike. I get an email from both of them. You know, it works out really well. And so I'm lucky in that respect. But he's my mentor because I needed an R01 level mentor. He's not inappropriate. He's fine. He's an injury researcher. He's got a bazillion people. If he included me in his time frame, he'd be way over 100%, which is also not allowed. You know, especially in our field, there aren't that many appropriately credentialed people you can go to the NIH with. There just aren't that many of them yet. And so there is some creativity required. You may need to identify funding, okay? One thing you should ask yourself is, do I really need funding? I mean, if you can do a research project without actually having to write for a grant, I don't know, you might as well just do it. So it's better, I think. We talked a little bit about this. Know your IRB. So when you get to an institution, read all their stuff. Find their forms. I keep realizing I didn't do that well enough, and so then I find out like, oh, my informed consent just expired. Bummer. I'm supposed to resubmit that. So you do want to be aware of all those things, but you also want to know people. You want to have names. You want to go to the, like if the IRB is presenting, like the head of the IRB is presenting in a little forum that you can go to that. Go up and meet him afterwards, something like that. And in your IRB, be realistic and be logical when you're identifying your risks and benefits. They may be overstating them, you may be overstating them, or everyone may be ignoring them. You need to be realistic. Okay, and this is, if we're going to do it, I don't know if we're still doing a breakout session, but this I think is what I'm supposed to mainly talk about, even though I've already been talking a long time. So the key with all of this is you need to start writing. Okay, so read a ton and then just write. I had one, my fellowship director told me that every morning you should get up and you should write for at least 15 minutes. Write something, okay? Because you need to be practiced at writing. We were talking at one point that no one teaches people to write a lot of times in our professional disciplines. Like we all have this language that we use for clinical work or something like that, and we never really learned how to write something that we'd want to read or that was clear. And so one of the places that I start, especially because I have this like tendency to go way too big picture on things, is I identify little questions and I write a research proposal. I don't let it be more than 2 pages long. I write a little background. I write 3 objectives because there's always 3. I don't know why. I did one that was 2. It was so disturbing. Don't know why. Methods, and don't skimp. Be absolutely clear that you can, that it's feasible. I mean, because if it's not feasible, you write 2 pages and then at least for now, you save it. Don't throw it away. But you're sort of done if you can't do the study. I mean, it's done. And so you really want to think through that. And also don't skimp on the methods. I don't know, maybe other people are better about this than me, but I'm really good at writing backgrounds and objectives. And then the methods, I get a little hazy. So, try and make that a real practice, be compulsive. And then think about with products, where could this be published? Who would you want to share it with? Would you want to present it to other colleges? Would you want to present it in, throwaways that might reach a larger audience along with, JAMA? But funding needs, maybe you need it, maybe you don't. Maybe you have a little tucked away from something else. Don't write grants just for the heck of it, I don't think. I mean, although people who do more RPT stuff may feel differently, I'm not sure. I was told, if I didn't need a grant, why should I spend time trying to get it? Like, just do the project. Think about timeline. Again, not one of my strengths in terms of realism. And then at least start with a few, collaboration if you're going to need it. There is a tendency, I know, in certain groups not in my division, but in other divisions too, all of a sudden have this list of collaborators. It's like, it's so long. And you're not going to get anything done. You're just adding people for the heck of it. And so at least at the beginning of a project, just, which disciplines do I need represented here? Who do I think I want to work with? Who can I work with for the next couple years? Start sharing that. Send around that 2-page report to the people that you just wrote were your collaborators. See if they like it. Make sure it's feasible. Make sure it's interesting. Because really, a lot of these projects are going to be several years. If you think like, yeah, this was interesting for 2 months, you're really stuck at that point. Like you really, especially if you got funding, like make sure you think it's interesting enough to be part of your life for a while. And again, see if you can make someone else interested in sharing that with you. And so then you just keep going and you keep writing, keep reading. Keep in touch with your collaborators, with your mentors. Go ahead and I schedule my mentor meetings 6 months out, and then I just change them. Almost every single one of the meetings actually gets changed at some point, but at least they're on the calendar. So I think that's a really good idea. And keep in touch with your family. It's always a good thing. So. My kids hate it when I have to write a grant. They get really upset. So basically, it's complicated. And we need some innovative research in family violence. And we also need to think of ways to bring that into arenas like quality improvement and translational research and all of these other areas that are, like, those are the big words that everyone's using right now, but somehow it got very cut off from research for some reason, which I don't understand. And so we need to make sure that that's happening. If you want to do this research, be passionate about it and spend enough time to do it right, because it's a new field. There are something of the field. And you were laughing about this, I always think it's a real luxury to be able to do academic medicine and to be able to do academic research. I see people who are really struggling in my clinic setting right now. And the idea that I somehow get paid to sit around and think about big ideas is so cool. And I told you, my kids think that is so weird, but they're 9 and 10, so they don't know these things. And so when I get disheartened or I have a headache because I've been staring at the computer, or I heard yet another NPR report about how sitting in a chair for 6 to 8 hours is going to kill me or something like that, I remember this is a choice I made, and it was a good choice, and I really enjoy what I do, and I really hope that it pays off, not in terms of just my satisfaction, but really contributing to something. So thank you guys so much for inviting me to do this. It's been fun meeting folks. And if we're having the breakout, we were going to see if people wanted to try and come up with research proposals. That's what we want to do. Sorry. Oh, I was going to put that back. Yes. See?